A patient crashes through the emergency department doors. Their hand is wrapped in just a blood-soaked towel after a violent run-in with a high-tensile industrial saw.
Right, a classic scenario.
Exactly. And your immediate instinct as a surgeon in training is going to be to unwrap that towel and look straight at the damage. But listen, if you do that, you have already failed the primary rule of trauma.
You really have.
You're listening to this deep dive today because you are staring down the barrel of your plastic surgery board exams, specifically the FRCS, and you need high-yield, purely factual breakdowns of complex surgical topics.
And today's mission is a rapid-fire question and explanation session, right? We're mastering hand trauma assessment and the highly tested, intricate physiology of tourniquet application.
Yes, but before we get into why looking at the hand first is a massive trap, I need you to do 3 things. Press follow on the show right now so you never miss our clinical breakdowns. Rate us if you learned something valuable today. And critically, get a premium subscription to access our dedicated journal club and clinical cases deep dives.
You're really going to need those for the exams.
Absolutely. All right, so the mangled hand is in front of you. What is the absolute first thing that must be established?
Well, you have to secure the patient's life before you even, consider their limb. It sounds like the most basic ATLS principle, but when you're faced with a dramatic, distracting distal injury...
Right, that tunnel vision.
Exactly. Tunnel vision is a real danger. The fundamental rule is to identify and treat all immediately life-threatening injuries first.
Because, the functional outcome of a severed flexor tendon really doesn't matter if the patient doesn't survive the primary survey.
Right. If they've got an unrecognized tension, pneumothorax, or massive hemorrhage elsewhere, the hand doesn't matter. Only once the airway, breathing, and circulation are definitively secured do you actually turn your attention to the upper limb.
Okay, so the patient is stable, and we're moving into the history. Now, for hand trauma, this reads less like a standard medical chart and more like a forensic crime scene investigation.
It really does.
We obviously need the basics, right? Hand dominance, occupation, and a very precise time of injury to calculate ischemia time. But then we get into the mechanism of injury, and the questions we have to ask become incredibly abstract.
Yeah, highly specific.
We need the configuration of the moving parts of the machine involved, the exact force it delivers, what material that machine normally cuts or deforms. If it's an electrical saw, we need the precise thickness of the saw blade.
Yeah.
If it's a knife, the exact vector of the blade. And we need to know the exact position of the patient's hand at the exact millisecond of injury. So why are we playing detective here? Why do we care about the abstract thickness of a saw blade rather than just inspecting the wound?
Because what you see on the skin surface is almost always a lie.
Wow, okay.
Yeah, it rarely tells the whole story of the trauma beneath. We ask about those specific mechanical details because they dictate the unseen zone of injury. Think about kinetic energy.
Right, the energy transfer.
Exactly. If you know a machine is designed to shear through high tensile steel rather than, say, soft pine wood, you instantly understand the immense kinetic energy that was just transferred into the patient's biological tissues.
So the tissues aren't just divided, they're crushed.
They are crushed and devitalized far beyond the visible laceration. And that thickness of a saw blade, that's a vital clue because it tells you the exact width of tissue that hasn't just been cut, but completely vaporized into dust.
You can't primarily repair a tendon if 3 millimeters of its length is simply gone.
You really can't.
Okay, and what about the position of the hand at the moment of impact? Why is that so crucial?
That is entirely about tendon mechanics. Tendons glide, right? If a patient tightly gripped a knife blade in full finger flexion and the blade sliced across the volar surface of their fingers, those flexor tendons were severed while under tension and fully excursion.
Oh, I see. So the moment the patient releases that grip and the hand relaxes?
The severed proximal ends of those tendons act exactly like snapped rubber bands. They retract deep into the palm or even all the way back into the forearm.
So if you don't know the hand position at the exact millisecond of injury, you'll just be blindly exploring the finger.
Right, completely unaware that the retracted tendon is hiding 6 inches further up the arm.
Man, okay.
Yeah.
So the history gives us the mechanism, and the physical examination reveals the reality. We transition from taking a forensic history to physically manipulating the limb. Our primary baseline checks are viability ruling out vascular compromise or impending compartment syndrome, assessing tendon, nerve, and bone integrity, and distinguishing true skin loss from skin that is simply avulsed, but, salvageable.
Standard primary checks, yeah.
Right. But when we evaluate for fractures and dislocations, the textbook signs are swelling, deformity, loss of function, tenderness, and crepitus. But when I feel abnormal motion in a digit, My brain immediately screams, fracture. Yet I know there is a trap here. What else hinges open like a fracture but actually isn't one?
A periarticular ligament
Oh,
rupture.
okay.
Yeah, if a joint is hinging open sideways, you have to differentiate between a bone moving where it shouldn't because the shaft is cleanly broken versus a joint physically opening up because the collateral ligaments that normally stabilize it have been completely torn.
So both present as abnormal motion, but the surgical management is obviously entirely different.
Completely different.
Let's move into the tendons.
Yeah.
Because this is where examiners just love to fail candidates. We assess them initially by looking at the resting cascade of the hand. Then we test the tenodesis effect.
Ah, the tenodesis trap.
Right. So a resident might passively flex and extend the patient's wrist. If they extend the wrist and the fingers naturally curl into flexion and they flex the wrist and the fingers straighten out, the resident might think, great, the tendons are in continuity. If I do a passive tenodesis check in an exam and rely on it, am I in the clear?
You have just failed the station.
Boom. Done.
Done. The tenodesis effect is incredibly deceptive and relies purely on passive mechanical linkage. A flexor tendon could be 95% divided-like, literally hanging on by a single microscopic thread of collagen, and it will still transmit the passive force of the tenodesis effect.
That's terrifying. So the finger will curl perfectly normally when you extend the wrist.
Perfectly normally. But the moment the patient applies active resistance, that remaining thread will snap. Furthermore, you have anatomical masking.
Right, with the FDS and FTP.
Exactly. An isolated complete division of the flexor digitorum superficialis, the FDS, can easily be masked if the profundus tendon running right beneath it is intact.
And it's not just the flexor side, right? The extensor side has its own built-in deception.
It really does. A junior resident might see a laceration over the back of the hand, ask the patient to straighten their fingers, see the interphalangeal joints extend, and assume the extrinsic extensor tendons are fine.
But the intrinsic muscles, the lumbricals and interossae, they can fully extend the IP joints even when the main extrinsic extensor tendons from the forearm are completely transected.
Precisely. If you don't specifically test extension at the metacarpal joints, the MCPJs, you will miss the injury entirely.
Which is exactly why we have to test the active independent motion of every single tendon against resistance. And we follow that with composite motion testing to assess functional grip types, power grip, and the 3 pinch grips, pure tip pinch, tripod pinch, and key or lateral pinch.
Moving on to nerve assessment, yeah.
Yes, nerves. We check sensation by lightly stroking within a specific nerve territory, strictly comparing it to the patient's uninjured hand.
Yeah.
But the autonomic assessment is where it gets really interesting.
Oh, the sweating test.
Right. A divided peripheral nerve doesn't just lose sensation, it loses sympathetic pseudomotor function. It stops sweating. So to test this, we use the tactile adherence test. You take a smooth plastic pen and lightly drag it along the skin.
And it will glide effortlessly over the denervated, completely dry skin.
But it will catch slightly with microscopic friction on normal, faintly moist skin.
It's a remarkably elegant bedside test that requires no specialized equipment. But, you also need objective, quantifiable sensory data, which is where static and dynamic two-point discrimination, or 2PD, comes in.
And if you don't have a specific discriminator tool, a standard paperclip folded into 2 points work perfectly.
It does. The critical technique, though, is that the pressure applied must be light enough that it never causes the skin to blanch white.
Oh, because if the skin blanches, you're pressing too hard.
Exactly. You're stimulating deeper pressure receptors, completely invalidating the test.
For the board exams, we are expected to memorize the exact guideline values for normal 2PD. It's 4 millimeters at the distal phalanx pulp, 5 at the middle phalanx, 6 at the proximal. Then moving into the palm, it's 7 millimeters distally, scaling up to 9 proximally.
And it gets much wider further up.
Yeah, the dorsal hand jumps all the way up to 15 millimeters, and the volar forearm is a massive 25 millimeters. Staring at a table of these numbers is mind-numbing. What is the actual functional logic behind this steep gradient?
It is entirely about receptor density and functional anatomy. Think of the skin's sensory system like the resolution on a computer screen.
Okay, I like that analogy.
Your fingertips are high-definition 4K monitors. They need an immense density of Meissner's corpuscles to perform fine tactile tasks like, say, reading Braille or feeling the edge of a coin.
Therefore, they can distinguish 2 points that are only 4 millimeters apart.
Right. Your volar forearm, however, doesn't need that resolution. It just needs to know if it's bumping into a wall. It's like blurry peripheral vision.
So the receptor density is incredibly sparse.
Exactly. So the points have to be 25 millimeters apart before your brain registers them as two distinct stimuli instead of just one.
That makes the memorization a lot easier. Now, for motor nerve testing, we look for specific paralysis indicators. Paralysis of the abductor pollicis brevis, the APB, most reliably indicates median nerve injury.
And paralysis of the flexor digiti minimi, the FDM, points to ulnar nerve injury.
But the trap here is anomalous cross-innervation, specifically the Martin-Gruber anastomosis. How does this anatomical quirk actually trick a surgeon into missing a severed nerve?
It is a brilliant physiological hijack. In a standard arm, the median nerve supplies certain muscles and the ulnar nerve supplies others. But in about 15 to 30% of people, you have a Martin-Gruber anastomosis.
That's a huge percentage.
It is. This is an anomalous branch in the proximal forearm where motor fibers from the median nerve cross over and physically join the ulnar nerve. Now, imagine that patient suffers a deep laceration at the wrist, completely severing their ulnar nerve.
So you test their ulnar innervated intrinsic hand muscles, expecting paralysis.
But the muscles fire perfectly. Why? Because those median nerve fibers crossed over higher up in the arm, bypassed the cut at the wrist by traveling within the intact distal ulnar nerve sheath, and are now successfully driving the ulnar muscles.
Wow. So if you don't know this variant exists, you will document an intact ulnar nerve and send the patient home with a completely transected nerve trunk.
Which is a disaster.
Absolutely. Okay, so we've mapped the damage and survived the traps of the physical exam. Now, the hand must be stabilized in a splint while waiting for surgery. We use the position of safe immobilization, the POSI, also known as the intrinsic plus or Edinburgh position.
Very important for the exams.
Right. The parameters are rigid. The wrist is in 0 to 30 degrees of extension. The MCP joints are cranked to 70 to 90 degrees of flexion. The IP joints are locked in full extension. And the thumb is fully abducted and pronated.
It's quite a specific posture.
I'm looking at this posture, and honestly, it looks like a medieval torture device. Why on earth don't we just let the traumatized hand rest in its natural, slightly curled, comfortable resting cascade?
Because if you leave an injured, inflamed hand in its natural resting posture, you are guaranteeing a permanently crippled hand. The POSI relies entirely on the biomechanics of joint contractures.
How so?
Edema fluid is essentially liquid glue. If ligaments sit slack in a pool of inflammatory edema, they will shrink, cross-link, and scar in that shortened position. Take the MCP joints.
Okay, the knuckles.
Right. The metacarpal heads are not perfectly round. They are cam-shaped, like an oval cam in a car engine. They are wider at the volar aspect. When the joint is straight, the collateral ligaments sit loosely alongside the narrow part of the bone.
Ah, so if you splint them straight, they scar short.
Exactly. When the patient later tries to make a fist, the shortened ligaments physically cannot stretch over the wider part of the cam and the joint is frozen. By forcing the MCP joints into 70 to 90 degrees of flexion in the splint, we stretch those collateral ligaments over the widest part of the cam to their absolute maximum length.
And the interphalangeal joints, the IP joints, are the exact opposite mechanism, right?
Right. At the IP joints, the risk isn't the collateral ligaments, it's the volar plate at the front of the joint. If you let the IP joints rest in a comfortable curled flexion, the volar plate folds up on itself and quickly contracts.
So you end up with a permanent fixed flexion deformity where the finger can never be straightened again.
Exactly.
Yeah.
Splinting the IP joints in rigid full extension keeps the volar plate fully stretched out.
And to tie the whole splint together, putting the wrist in 0 to 30 degrees of extension decreases the MCP joint extension forces via that tenodesis effect we talked about earlier, effectively taking the tension off the flexor repairs.
It's a beautifully engineered position.
It is. Finally, leaving the thumb abducted and pronated prevents the dreaded first web space contracture, which would otherwise physically bridge the thumb to the index finger and destroy the hand's ability to pinch or grasp. So we force the hand into this rigid POSI splint to save the joints. But a splint doesn't repair a vaporized tendon or a severed nerve.
No, it doesn't.
To actually fix the anatomy, we need to transition to the operating theater. You cannot perform microsurgery on a 2-millimeter nerve bundle in a pool of blood. We need a completely bloodless field, which introduces the entirely new physiological minefield of the tourniquet.
Ah, the tourniquet.
Modern units are pneumatic and microprocessor controlled. Mechanical rules are strict. Use the widest cuff possible because a wider surface area distributes force and occludes arterial flow at a lower pressure. Ensure wrinkle-free padding to prevent localized skin necrosis.
And you have to be careful with exsanguination.
Right. Avoid aggressive exsanguination rolling and Ismarch bandage tied at the arm to squeeze the blood out. If there is an active infection or malignancy present, to prevent physically milking bacteria or tumor cells into the systemic circulation.
Crucial step.
For pressures, the suggested maximum is 250 millimeters of mercury for the upper limb, or simply 100 millimeters of mercury above the patient's systolic blood pressure. And then there is the golden rule taught to every single surgical resident, the strict 2-hour maximum inflation time.
Right, the 2-hour rule.
I have to challenge this. Is this 2-hour limit a hard biological deadline? Like, does the limb just undergo spontaneous, irreversible necrosis at minute 121, or is this just dogma?
It is much more dogma and convention than hard biological law. If you look closely at the literature, there is surprisingly little solid evidence supporting a universal 2-hour cutoff.
Really?
Yeah, the variance in studies is massive, with some data suggesting safe ischemic times of just 45 minutes, and others showing limbs surviving up to 4 hours of continuous inflation.
Wow, 4 hours.
The 2-hour rule exists as a safe convention to mitigate extreme risk. What is actually biologically essential is how you handle the reperfusion break if the surgery goes long. If you hit your limit, you must deflate the tourniquet and wait a minimum of 20 minutes before reinflating.
And why exactly 20 minutes?
Because of the profound metabolic derangement in the limb. While that tourniquet is up, the arm is starved of oxygen. The tissues switch to anaerobic metabolism, producing massive amounts of lactic acid.
So the pH just drops.
It drops precipitously in the venous beds of the limb, causing severe local acidemia. That 20-minute reperfusion window is the physiological time required for the circulating blood to wash out those acidic metabolites, reoxygenate the tissues, and allow the cellular pH to normalize before you resanguinate the arm and restart the ischemic clock.
Let's look at what happens if we push those limits too far. If a tourniquet is too tight or left up too long, it stops being a helpful hemostatic tool and becomes a source of profound local and systemic trauma.
Locally, it's pretty brutal.
Yeah. Locally, the muscle tissue suffers from direct mechanical compression directly beneath the cuff, profound ischemia distal to the cuff, and then a devastating reperfusion injury cascade the moment oxygen is suddenly reintroduced to the starved cells.
And the nerve injuries are highly testable.
Yes, most of them occur directly under the cuff. This isn't just because the nerve is deprived of blood. It is a mechanical crush injury that disrupts the myelin sheath and physically distorts the nodes of Ranvier.
And we can quantify that specific risk. Tourniquet-related nerve injury has a reported incidence ranging between 0.1 and 8%.
That's not insignificant.
Not at all. The silver lining is that the vast majority of these lesions are neuropraxia's temporary conduction blocks. They will recover spontaneously, but you have to counsel the patient that this recovery can take up to 6 agonizing months.
Vascular injuries are rare, but they do happen, usually when an underlying atheromatous plaque is physically ruptured by the crushing force of the cuff. We also see skin injuries pressured into necrosis from wrinkled, inadequate padding, or devastating chemical burns.
The chemical burns are awful.
If you use an alcoholic skin prep like chlorhexidine, and it pools or seeps beneath the tourniquet padding, it gets held tightly against the skin under intense pressure for hours. It will literally burn the epidermis off. Then there is tourniquet pain.
That's a fascinating physiological phenomenon.
It's a dull, severe aching pain that reliably develops after 10 to 20 minutes of inflation. And strangely, a patient can start screaming from tourniquet pain even if they have a perfectly functioning regional anesthetic block that is numbing the entire arm. How does the pain bypass the block?
It comes down to the fundamental physiology of peripheral nerve fibers. The pain of a surgeon's scalpel cutting skin is sharp, and it is transmitted by myelinated A fibers.
Okay, A fibers.
A fibers are highly susceptible to local anesthetics, but the deep, crushing ischemic ache of a tourniquet is transmitted by unmyelinated C fibers.
And C fibers are different.
Very different. C fibers are significantly more resistant to local anesthetics. It requires a much higher concentration of the drug to block a C fiber than an A fiber, so the standard block works perfectly to silence the A fibers at the surgical site, but the deep ischemic crush bypasses the blockade via those resilient C fibers.
Wow. And here is where the physiology gets really wild. The systemic shock of the tourniquet. When we tightly wrap an Ismarch bandage up an arm, squeeze all the blood out of it, and inflate that cuff, we aren't just isolating the hand.
No, you're changing everything.
We are fundamentally altering the patient's entire hemodynamic system. Exsanguinating an upper limb actually increases the patient's central circulating blood volume by up to 15%.
15% is a massive volume shift.
Right. In a healthy 20-year-old, the heart easily absorbed that fluid shift. But in an elderly patient with severe cardiac dysfunction and very little cardiac reserve, acutely forcing a 15% volume overload into their central circulation can precipitate acute cardiac failure right there on the operating table before you've even made an incision.
It's a huge risk.
And then at the end of the case, the surgeon calls tourniquet down. I always think of this moment like a failing dam suddenly bursting. What exactly floods the system when that pressure drops? And why does the anesthetist suddenly lean forward and stare at the monitors?
When that dam breaks, the anesthetist is managing two violent hemodynamic shifts simultaneously. First, there is a massive drop in systemic vascular resistance.
Because the arm opens back up.
Exactly. An entire limb's worth of empty vascular bed suddenly opens up, and that 15% blood volume shifts rapidly back out of the central circulation and into the arm. Second, the built-up ischemic metabolites from 2 hours of anaerobic metabolism, a toxic soup of potassium, lactic acid, and severe acidosis flood out of the arm and wash directly into the central circulation.
And what do those metabolites do?
These specific metabolites cause direct chemical myocardial depression. So the heart is facing a sudden drop in central venous pressure, a sudden drop in mean arterial pressure, and its actual pumping mechanism is being chemically depressed exactly when it needs to be compensating for the pressure loss.
That sounds like an anesthetic nightmare.
Yeah.
And the systemic shock waves don't stop at the heart. From a pulmonary perspective, as that highly acidic, hypercapnic blood hits the pulmonary circulation, the anesthetist will see a massive spike in increased end-tidal CO2 on their monitor.
Which can be alarming if you aren't expecting it.
Absolutely. There is even a recognized documented risk of acute lung injury, specifically associated with the inflammatory cascade of limb reperfusion. Neurologically, the cascading effects are just as severe. The sudden increase in PaSO2 in the blood acts as a highly potent cerebral vasodilator. The blood vessels in the brain dilate, which increases cerebral blood flow.
Which triggers a vital, hardwired reflex. The brain senses that sudden surge in blood flow and tries to protect itself from elevated intracranial pressure. To counter it, the body initiates a reflex decrease in systolic blood pressure.
So the blood pressure drops again.
Right. For a normal patient, this is just a transient dip on the monitor. But if you are operating on a polytrauma patient who also has a traumatic brain injury, their brain relies entirely on a high systemic mean arterial pressure to force blood into the swollen skull and maintain cerebral perfusion.
So that reflex drop in systolic blood pressure triggered by the tourniquet release
Can critically and catastrophically decrease their cerebral perfusion, starving the injured brain of oxygen.
It is absolutely incredible to think about.
Oh, yeah.
A simple piece of pneumatic plastic and Velcro wrapped tightly around a bicep doesn't just isolate the hand. It intricately and dangerously ties the local microscopic mechanics of hand surgery to the absolute highest levels of cardiovascular and neuroresuscitation physiology.
It's all connected.
It really is. Next time you hit that inflate button in the theater, consider the systemic storm you are holding back and the massive physiological cascade you will unleash when you let it down. We want to hear from you as you prep for your exams. Leave a comment or a specific question about today's surgical breakdowns.
We read all of them.
We do.
Okay.
And remember, get your premium subscription right now to unlock our dedicated journal club and clinical cases deep dives to ensure you pass. Keep studying, and we will see you on the next deep dive.